David Browning, Medtronic Spine, Red Medical. Guys, come on up. Part of the four-headed team, along with Steve Bales, making our fifth member of the quartet. It's not really a quartet. So Evan Miller, Parker Thieneman, Jake Griffey, Steve Bale. Steve's the one responsible for all things alarm stealth station. So when we have problems, we call Steve. You guys remember him? He was here for years and years with NuVasive, and then we lured him to the dark side. So, yeah, thanks, guys. So this morning, who's got a mic? Jake's got a microphone. So this morning, like I said, going to be the best training ever for you guys. It's going to be a little bit interactive. We're going to start off with some general anatomy, pathology, things like that. Roll into what is the OR, what is stealth station, and then a little bit of hands-on for everyone. So let me get this thing rolling. All right. So kind of went through that. So here we go. 3 general areas in the human spine. We've got cervical, thoracic, and lumbar regions. So first quiz of the day. How many cervical vertebral bodies? 7. Oh, hold on, Aaron. All right, there's 7. Aaron. All right. How many in the thoracic spine? All right. Dana. 12. All right. For 2 teams. All right. Lumbar, 5. All right. You guys were too good. All right. So let's talk about what's going on with the vertebral body. They're all pretty much the same, a little bit different shape, bigger, smaller, but start with the anterior arch. So there we go, anterior arch. That consists of the vertebral body and the first 1/3 of this tube of bone called the pedicle. So posterior arch is going to consist of your lamina, the roof that protects your thecal sac and spinal cord, spinous process, facet joints, transverse processing. I guess, yes. So this will make up the vertebral foramen, the tube where all the signal from your brain to the rest of your body comes and goes from. A little neural network. So here we go, quiz time again. What is this? Who said that? All right. The body. All right. Parker. That's up. It's not hurt anyone. All right. Next up. What is this structure? Who said it? Who's first? Oh, we're not showing hands. All right. Somebody tell me. All right. Right here. What are we looking at on this part of the vertebral body? Anyone? Keith, come on. Come on, Keith. All right. Knowing that is the lamina. That's the roof. So when Dr. Chambers does a laminectomy, what's going on? The vertebral foramen is tight due to the ligament flavum, maybe some due to degenerative disc disease. The disc is pushing out. So he does a laminectomy to take the roof off to give this more room. So it's basically constricted that tube. So now he opens it up so the signal's free. One more. What are we looking at here, team? I don't think I heard the. Boom! Transverse process. What's your name? Allie. Why aren't you in the spine room? You know so much. All right, welcome, Allie. All right. All right, continuing on. a few more little things. So the pars interarticularis. So that stands for the land between the facet joints. So this is kind of an interesting spot. So when patients have an isthmic spondylolisthesis, where the vertebral bodies have shifted one over another, a lot of times they have a pars defect. You'll hear that. So congenitally, they were born with maybe a weakened pars, or as they've either gained weight or something, it's overstressed that. So they have a natural fracture that causes the vertebral bodies, rather than lining up, one shifts over the other. So superior articular facet, process or facet, inferior. So those work together to kind of, because the spine is those 26 vertebral bodies, kind of, they're all solid bones, but they have to move to allow us to be flexible. So that's kind of the connection point with those facets and the disc to allow mobility, so we don't have this rigid spine. Right now, okay, so that's kind of leads into the functional spinal unit. So we've got two vertebral bodies, facet complex here, disc, and then we've got the intervertebral foramen. Anybody know what happens with that intervertebral foramen? That's where our nerves exit. So you've got your thecal sac coming down, your nerves will exit through those little holes and go out through your muscles to the extremities and pick up signals, send signals to and from your brain. So part of that functional spinal unit is the disc. This is kind of your shock absorber. It does, in normal anatomy, your disc in that anterior arch is going to carry 60% of your body's load when in a natural state. So what's going on here? This lamellae is, it's almost, think of it like the casing of your radial tire. So it goes at 30 degrees and goes back and forth, creating this strong outer ring. And as that ring, if that ring weakens, then you have the nucleus that pops out, herniated disc. What happens with that herniated disc? It pops out, starts pushing on a nerve or pushing on the thecal sac. So all of a sudden, those foramen that we talked about before, the little holes where the nerves exit and the spinal cord runs through, now it's small. Sometimes we can live with that. If it happens slowly over time, your body adapts and it's okay. But in an acute situation, it's going to cause radicular pain, or if it constricts in the spinal cord area, your gait goes off, you have weakness, paralyzation, things like that. So, all right, let's move on. So again, we're talking about compression and compression. So you can kind of see, here's your nerve exiting, like I talked about. So you can see as this compresses, so this kind of leads us in, we'll talk a little bit more about the degenerative process, but can't go too far away. But with time, if due to degeneration, your disc is going to lose hydration and nourishment. So all of a sudden height goes down. Well, what happens when height goes down? That hole gets smaller for your nerves to exit. So sometimes, and that will also load your facet joints in an unnatural way. So with that, loading your facets more, as we know with Wolff's Law, your bone is constantly modeling and remodeling due to stress. So if it's working and those two facet joints are working harder than they naturally should be, they're going to grow more bone. So if you've been in the spine room and Dr. Chambers is taking out these giant facet joints, they're not supposed to be that big. But due to the degenerative process, they've been just constantly grinding on one another. And your body's like, oh, we need to lay down more bone. So it's trying to fuse itself so it stops moving. But in the process, it closes up those foramen and won't allow, it doesn't leave enough room for your nerves any longer. So again, you can kind of see the intervertebral foramen. So you can just imagine that as this height reduces, this will get smaller, and these facets will get bigger. So you kind of lose height, and you're gonna have encroachment posteriorly here as well. All right, this kind of just outlines all the nerves and as they exit. So it's not spinal cord all the way down. Spinal cord ends around L1 at the conus medullaris. So sometimes we have, Dr. Cameron may have an add-on for Cauda equina syndrome. That's when, so that, with that comes bowel incontinence, and it's kind of a sudden onset. That's usually an extruded disc fragment right in this area, right at the conus, and he'll go in, decompression, patient usually, recovers well, but it's just this acute kind of injury where there's a herniation right at that area that causes that dysfunction. So down here, the Cauda equina, this is why when we do T-lifts, he uses that love nerve root retractor. We're not retracting on the spinal cord. Imagine it's in Latin for a horse hair or horse mane. So it's just all these long fibers of nerves in the thecal sac that kind of float. So he can retract on that. If we were up here in the thoracic spine or cervical spine, you can't. You'll cause it, since it's spinal cord, you'll cause an injury and a deficit to the patient. So that's why if we do a thoracic procedure, it's generally just the decompression. There's not going to be an inner body fusion or anything like that, just the decompression only. The extreme circumstances, if we had to do some sort of corpectomy up there, and we would go at a wider angle. Yes.
The longer you let that go, is that like long-term for the patient?
Yeah, I think that'd be a better question for him, but I think they usually want to get it sooner rather than later, because yes, the sooner they get it, the less chance that it's an ongoing problem. Yeah. All right. Quiz time. How many nerves are in the cervical spine? Anyone? Haley, you've seen some of this presentation before. Do you remember? All right.
Got an answer.
Yes, that is right. 8. So every other area of the spine, the nerves exit below the level they're associated with. Cervical spine, you get an extra one. So they exit underneath that. Now we're in degenerative disc disease. All right. This is the bread and butter of what we see in room 11. As we age, again, you can see, so this is your vertebral body, disc, vertebral body. So here's the foramen, ligamentum flavum. So this is the yellow ligament. So you've got anterior longitudinal ligament, posterior longitudinal ligament, and ligamentum flavum. So posterior longitudinal ligament, ligamentum flavum kind of are the borders for the spinal cord for fecal sac. As we age, this ligamentum flavum thickens. And a lot of times, Melissa and Aaron have probably seen it when he pulls that tough stuff out after, while he's doing the laminectomy, it just comes out. It's just this tough, thicker tissue. And I wish we had an MRI, but you can see if we had an MRI, you'd have this nice fecal sac with white signal, and then all of a sudden that white signal gets choked off right there where that buckling of the ligament flavum. So again, that's when he does the decompression part. So sometimes it's a decompression and fusion, sometimes just a decompression. If he doesn't have to go out wide enough or the facets aren't involved, where he needs to destabilize the spine. And we'll kind of get into that a little bit later. So, all right, there you can see, look at that buckling. So here's the spinal column. This is kind of a herniation here, kind of causing that signal to be lost in that stenosis of the cord for the fecal sac. So then we have spinal deformities. So We don't do a ton of that, just because, usually that stuff is saved for, it's usually adolescents. So you see that at Riley, sometimes at the adult deformity, we'll occasionally do here. But there's not, with adult deformity, the goal isn't always to get them perfectly straight. It's to get them better and to, open things up. And with kids and adolescents, you're trying to straighten them out and stop the curve from progressing. Kyphosis, Schuerman's kyphosis, this is usually a disease that younger males, you see this in males more than females. It's just this kyphotic disease is kind of tough. So they'll try to straighten them up as much as possible. And then again, this is what we talked about, a little spondylolisthesis. So here's a pars defect right here that we talked about earlier. So inferior articular facet, superior articular facet, there's a weakness here, and you can kind of see. So look how 4, 5, 3, they're in line. Here's the sacrum. They split all the way forward. So it's this big shift. So imagine you've got these two circles and your nerve's supposed to exit there. It closes off. So you're going to have lots of leg pain there. So to try to reduce that, to get those circles, the foramen back to the circle to allow those nerves to exit. And then of course we've got, occasionally we'll deal with this here. You get some sort of trauma where we'll bring them in, decompress, fuse. The goal here is to stabilize the spine again and decompress the cord or the fecal sac. So some key concepts that Dr. Chambers will think about during a procedure is balance. Our body wants to be in line. We want our head and neck straight down. So the patients, as they gain weight, you have to accommodate that. Their body changes, and sometimes they're leaning forward and the degenerative changes. But ultimately, we want to leave them with lordosis that brings them back where their head is straight down over their sacrum and their hips. So, because imagine standing, and there was a surgeon, Paul Kramer, that told me that years ago when I started, I was just asking him some questions, and he said, well, just imagine if someone with flat back is pitched forward like this, if they don't have lumbar lordosis. And he said, just stand there for 5 minutes. Well, after a minute, you feel how tight your back muscles are. So you're just constantly under tension there, rather than when you're standing straight up, your muscles are allowed to relax. So having them in the proper alignment and posture is going to help them quality of life, and also it helps reduce adjacent level syndrome. So then it helps prevent coming back for an additional level, potentially. There's no guarantee, because these patients are predisposed to some of these spinal pathologies, and you may not change it, but you give them the best chance at extending between surgeries or preventing that next surgery. So again, now we're talking about they're going to restore or maintain alignment. We need to prevent motion, because a lot of the process is to destabilize the spine by decompressing. He's taking so much bone away to decompress the areas and allow the fecal sac and the nerves to signal freely, that our body isn't strong enough, or we've destabilized it and taken key components away. So what do we need to do? We need to add instrumentation and fuse those areas. And all of our instrumentation is going to be temporary until the body heals. If the body doesn't heal, our instrumentation will fail. It's not just ours, it's everyone's. The body needs to heal and fuse. So he'll put in bone graft, posterior laterally, inner body bone graft, those things to just help the body heal and lay down bone so the body has its strength back. So where do we get bone from? From the patient, sometimes from the hip. We've got allograft from cadaver, and then usually we get our carrier from our friends, the cows, or xenograft, the bovine collagen carriers, and so many things that you guys probably see in the OR. So now we move on to everybody has, well, not everyone, ACDF, anterior cervical discectomy and fusion. That's kind of one of the, it's one of the most successful surgeries for patients. It's one of the most common surgeries that patients present with. They're going to have radicular arm pain, shoulder pain. Sometimes they're myelopathic, so the central cord is being compressed. So this approach will go in from the anterior to treat a spinal cord or a nerve issue. So you can see Dr. Chambers will place the trim line retractor, and here's his view. So you've got vertebral body, this, and this is kind of the axial cut of what we're looking at. Spinal cord, here's our nerves exiting. So imagine a disc herniation here, pushing on that nerve. All of a sudden, that nerve runs down to your arm. You've got arm pain. So he goes in with that distractor, leans, let's just get back. He'll clear out all this disc, take down the posterior longitudinal ligament, and then a lot of times toward the end of the case, he's got that one Harrison, and he's plucking, and then he'll ask for Surgiflow or Cottonoid. That's when you know you're about done, because there's these epidural veins right in here that's the last little bit, and then all of a sudden he takes that out, it's going to bleed, then he'll feel around with a nerve hook. He feels in here to make sure there's a clear path for those nerves exiting, and then all of a sudden we're going to trial, irrigate, put an implant, and put a plate on. So this just kind of shows it from the other side. We're replacing the disc with these bones. All right, all the different plate options. This is the old Zephyr plate that he used to use. Lannis plate, Elite. Quiz time. What plates Dr. Chambers currently use? Come on. Come on, Claire. The circulators should know this. They see my handwriting. Come on, Tommy. Zevo, Atlantis Elite, Divergence. Come on, Connie. All right. No worries. Zevo. Oh, you did? Oh, I'm sorry. I'm sorry. It's being corrected. This just shows some of the different interbody options. Dr. Chambers uses allograft, but he used to use a PEEK with the DBM inside. So it's just surgeon preference, and some insurance companies or payers will pay for a PEEK implant, some won't. He's settled on allograft, and it's worked well for him. So another option for anterior cervical is cervical arthroplasty, where you don't fuse. Not every patient is a candidate for this. There's indications are more narrow for this than with a fusion procedure. Dr. Chambers is trained on this. I don't think he's done one. But there's pockets where some will, and some surgeons believe in it, some don't. The success rate of an ACDF is high and reproducible. That's why many surgeons haven't moved to arthroplasty, but this is the newer system. So the procedure is exactly the same. The goal is to decompress and then restabilize the spine, but you're stabilizing the spine where it still has motion by placing an implant in there. So this is the old Prestige, where the immediate fixation was through screws. This is the newer Prestige LP. It has these little rails or channels that you prep into the vertebral body, and it's placed in there and immediate stabilization. There's no neck collar or anything the patient leaves with. So they leave and they do have some limited activity for a few weeks, but hopefully they just kind of move on and there's no real restrictions. There's some UFC fighters that have those and they still fight. I don't know that it's advisable, but they do. So it's pretty resilient. With navigation, you guys have seen that we've done more of this. Yeah, not this yet, but posterior cervicals because of enabling technology and the ease and the added confidence and ability to see where you're going versus just using fluoro and with certifications that are thicker, tougher to see. This allows Dr. Chambers with more confidence to take on these tougher cases, these posterior cervicals, because you'll see that you can see structures that you can only imagine when you're looking at a 2D fluoro shot. You're able to see the foramen and the vertebral foramen and where the blood supply is, where everything is. So it's really eye-opening and it just enhances what your surgeons can do. Just this is, all right, all of our thoracolumbar options as far as surgical strategies. So Dr. Chambers will pretty much, it has done all of these. So straight posterior approach, typically decompression and fusion. So when you see that on the board, what are we doing? We're gonna take out the lamina, open this up, and then we've destabilized it, like I said earlier, but then we have to add screws and rods to stabilize that spine. And then of course, lay down bone graft along these transverse processes to allow everything to that bone to bridge and heal. Transforaminal T-lift, everyone's seen that. That's when we add inner body. For him to access and do that, we have to create a corridor, and I think we'll get there with by taking off the cassettes. Another one where we have some help is an A-lift. So we're gonna, this is very similar. This is an ACDF lumbar region. We're down low doing the same thing. This is someone that may have degenerative disc disease, so that narrowing or spondylolisthesis, where indirect decompression, where he doesn't need to go back there and necessarily do a laminectomy. He just needs to increase height because either they're slipping forward in that intervertebral foramen is closing and it dings the nerve as those two vertebral bodies move, or just creating extra height. So instead of it being down, those two holes line up to allow that nerve to exit. So that's called indirect decompression. So this is a good way to get indirect decompression. You can get a large inner body in there, restore height, and then either with a plate or flipping with perk screws, stabilize. And you guys noticed we do more perk screws now than we ever did because of the StealthStation. Again, same as with posterior cervical. Just the way it enhances and gives you the ability to add more tools to your toolbox. All right, quiz time. Whose hand is this in an A-lift exposure? Aaron. Boom. So this is some of the stuff that Dr. Thompson is dealing with when we go down there. We've got the bifurcation of the great vessels, we've got sympathetic, all the sympathetic plexus. So sometimes they'll go transperitoneal, they'll go retroperitoneal other times. But on a 5-1 case, this is always the question because on the map, there's always 4-5 and 5-1. What's the difference? Okay, well, usually at 5-1, Why we don't have a beanbag is because they're splitting the goalposts here. They really don't need to move much because they're going right through the bifurcation. On a 4-5, if they want a beanbag, they want to try to just cheat that patient so those vessels in the peritoneal contents shift over just a little bit to give them more of a working window. And you'll see that more. That's kind of the philosophy behind OLIF that we'll show here in a little bit. So this is direct lateral. This is where you used to see Steve a lot with XLIF. So with this procedure, minimally invasive, usually the left side up, because we want to avoid the vena cava. So we'll keep the aorta because it's a little bit tougher. If we have an oops moment, we can bounce off of it. But with direct lateral, you go through the psoas muscle, and through the psoas muscle means that there's a lumbar plexus. So you've got this plexus full of nerves that have exited your spine, and they go down to your legs, but they travel through the psoas. So with neuromonitoring, Dr. Chambers goes down with those dilators, and we stimulate each time, and it tells him it's basically a call and response. It's sending out a signal, and based on that threshold where they get a response in the leg, he knows how close he is to a nerve. So if we get down to a 1 or a 2, we're close. He'll move around. Okay, we're going to get to an 8. He knows that he's happy with an 8. It's a safe working distance. He'll continue to dilate up. Once that retractor's in there, he'll also test to make sure, okay, this is a safe area to make an incision. We're not going to go through any nerves and have any issues. With that, the next evolution from direct lateral, patient's position is saying, now we don't have to go. So here's that lumbar plexus, those nerves running through that psoas muscle. With OLIF, you no longer have to go directly through that psoas muscle. So you're going between the great vessels and the psoas to get to the same area, to access the spine. And again, it's a broken record. We're doing the same thing as with an ACDF, with an ALIF. We're going to remove the disc, increase disc height with a large graft, indirect decompression most of the time. But with this, you prevent potential, one of the downsides with the direct lateral, when you have retraction with the psoas, even if you're not close, just that retraction for 15 or 20 minutes during disc prep can leave them with thigh pain, thigh weakness. Sometimes it generally recovers a few days, few weeks, but sometimes, surgeons are trying to avoid causing any harm. So OLIF has become a more popular technique in recent years. Here are some of the options for ALIF. We've seen this is what Dr. Chambers will use on OLIF. So if we use a plate, they're independent of one another, but he can go in, stabilize. That means we won't have to go posterior. So, quiz time. What 2 systems on an ALIF without a flip does Dr. Chambers use? Aaron, you're done answering. Melissa should know. Perimeter. 2 systems. What else? We'll give you the hint. What's the perimeter?
Certainly, no.
The peanut gallery. Shots fired. So, okay, this is wrong surface. All right, this is kind of showing a posterior approach. So this technique, a PLIF is what they would call it. Usually they'll place 2 interbody grafts, but you'll see laminectomy's been done. They don't take off the entire facet joints on either side. They just take enough But again, that destabilizes the spine enough where they need to put interbody grafts here and here. So one of the downsides with this is, and why most have moved away from it, is you've got to retract the fecal sac 2 times, 2 ways. It gives you twice as many chances to cause a problem. So most have adopted the transforaminal technique where you will take out this facet joint or a facet joint to free up that nerve. So a lot of times it'll be the side that the herniation's on. So they'll take off that facet to be able to get to that herniation that's causing stenosis and causing irritation to the nerve. They'll retract one side with the love retractor, do an incision, take out your disc, place bone graft in there, place an interbody fusion device in there. So that interbody fusion device with the little capstone spacer, it's a temporary prop until all that bone graft heals and grows that bone. So eventually, in years to come, post-op x-rays, you'll just see a solid column of bone, and you'll just see these little metal markers that are in there from the peak interbody graft. That's kind of what it would look like on the axial. And there's different types of interbodies. There's expandables, there's static, there's these little, some call them banana cages or boomerang cages. Again, surgeon preference. Everybody's got a quiz on that one. Posterior. So yeah, posterior disruption of posterior tension band. So posterior tension band is supraspinous ligament, interspinous ligament, your sets, everything keeping you from going forward. By doing a laminectomy and doing that decompressive surgery, that posterior tension band again is disrupted. So what do we have to do? Again, stabilize. The job Dr. Chambers is doing is a lot of times destabilizing the spine and then again giving it temporary fixation until the body heals. Just kind of more the same, showing what we kind of do on some of those longer constructs. This would be very similar to maybe a scoliosis case or something. So a lot of bone graft, a lot of screws. Side view, so that imagine years ago we would do perk screws here before the O-arm, and we've got 2 C-arms in there. The room's crowded anyway. You start getting 2 C-arms, everybody trying to get all the views and guide wires and all the craziness. And with the size of patients, a lot of times it just wasn't easy. You couldn't get the shots that you wanted. But again, with O-arm, it's kind of opened up the possibility for more minimally invasive procedures that Dr. Chambers can do. This just kind of shows some of the tubular style minimally invasive retractors that you guys, Metrics tubes, Dr. Chambers uses, little lateral retractors, those things. So now we'll talk about a little bit about the biologics side of things. So again, dead people, autograft from the patient themselves, and then what the one that does the heavy lifting for Dr. Chambers is Infuse. And Infuse is a protein or a peptide that basically will turn an undifferentiated stem cell into an osteoblast. So it signals out and recruits cells to, okay, I'm going to be bone. So in the master graft carrier that he puts it on is osteoconductive. So it's a scaffolding. Bone likes to attach itself to that and grow there. So he's adding that protein to that scaffold and developing a nice healing environment or a welcoming environment for bone to grow. And it, as you guys have seen in some of the revisions, it works. So now, the start of the show, our enabling technology. So we've moved, oh yeah, Cindy.
Is there like a weight Like, it's not- Or does it matter?
Well, so maybe a direct anterior approach. So there's no weight limit. Okay, can we get size? But a lot of times that's why we do O-lift. So think about this giant belly. Okay, going straight through it is going to be a problem.
Right.
But you stick that belly on its side and let it hang, all of a sudden we're all the same size from the side. So all of that falls away. And that's one of the true benefits from O-lift is that you can get that anterior approach without having all the retractors because there's no big bone people. Everybody, the skeletons are the same. You know, there's some that are bigger. So when you put them on their side and it falls forward, oftentimes it's always a 13 or a 15 blade that we use, no matter how big or small the patient. It's just how it all works out because, and that's one of the huge benefits of O-lift. You're not there working through the plexus, and it takes size out of the equation a lot of times. And that's, so with a patient that's larger, so think about an O-lift, we can put them on their side, get a big interbody graft in through an incision, maybe this big, and then flip them and do percutaneous screws through two small incisions this way. If we had to do, if Dr. Chambers had to do that open, imagine to get out wide on the spine, wide enough on the spine, you'd have to have an incision this big, even just with the one level, just to get enough retraction on the tissue to get where he needed to be to place instrumentation. So good questions. All right, so all of our stuff, you guys have seen the big O-arm in the room, stealth station, right over there, right over here. This is the Mazor X stealth edition. It's kind of the next evolution, working through building on what the stealth station O-arm are. They're all starting to merge. So with Mazor, surgeons can pre-plan. It's different, but the same as stealth station. They're able to see everything, but with Mazor, they take a preoperative CT scan, or they can do an intraoperative O-arm scan, but they pre-plan all their screw trajectories. And those are loaded into the robot, and the robot's arm and end effector move to that spot, and they place them rather than a surgeon basically having the freedom that you guys will see to move independently and kind of change trajectories intraoperatively. It's a preference thing, and planning larger constructs and longer minimally invasive surgeries, the robot is very beneficial because you can make sure all the screws are lined up perfectly so that when you pass a rod minimally invasively, that everything lines up and it's captured. Downside to that is it takes longer intraoperatively. Registration does take longer than with O-arm because you guys have seen O-arm and stealth registration. We verify instruments, we spin, and we're there. So there's pluses and minuses. And Dr. Chambers' practice, not a lot of long deformity, minimally invasive type stuff. Robot, maybe one day it'll be there, where registration is the same and as quick as, that's our hope, as what is this with O-arm and stealth station currently, but time will tell. We'll get there. Yes.
Hannah doing that navigation for
The robot? Yeah. So one of our accounts in Richmond, the two surgeons out there do use it. One uses it without the navigation component. He'll use guide wires and he still uses fluoro for confirmation. The other surgeon uses the navigated portion. There's a couple surgeons at OrthoIndy that will use it. Dr. Poulters, he does a lot of long, minimally invasive deformity corrections, so he finds it beneficial for that. IU Methodist has one as well. So there's 4 sites, 5 sites with Mazor in Indiana, but there's probably 40 O-arms, 40 O-arm self-station sites. So it's growing, but the overwhelming, and Indiana's been at the forefront with enabling technologies for years. The second, I think it was the second O-arm was actually, ever was placed at St. Vincent 86th Street. So Indiana has kind of been ahead of the rest of the country because I know in recent years, only 25% of spine procedures nationally were navigated, but in Indiana, in central Indiana especially, it had become the standard of care. If it was under 25% that weren't navigated, it was an overwhelming majority that what we're using the enabling technologies. So what are the two components that we have? StealthStation and the O-arm. What is the O-arm? So it's the imaging device that basically takes the snapshot in time of that patient right then. So imagine, okay, we're not relying on a preoperative CT scan to push to this to kind of hope everything lines up. We're taking that snapshot in time intraoperatively, and it's converting it into a 3D reconstruction where we can see, not just the sagittal and an AP, we can see an axial, a coronal view, all the things, and cut through all those slices. And this is kind of just a video showing, if anybody hasn't been into room 11, of what happens. So it opens up to a C, we go around the patient, it closes. So one thing key here is when we're doing this, always make sure no drapes get caught in here because the imaging acquisition device inside there rotates. So if there's any drapes caught in there, it's going to bind that and then it's going to get stuck on the patient. So then it pushes it over to the MVS, the mobile viewing station. We can make sure, okay, we can see what we see. We got a good scan. We've got the levels. Now from there, it's all pushed over to the StealthStation. The StealthStation does all the heavy lifting from there. It's where our tools are loaded. There we go. All right. So StealthStation, it's our tracking station. So you've got the camera with the two infrared lenses that where you want to, it's viewing down here. So it wants to see the patient reference training and then also the navigating tools all at the same time. So by doing this line of sight, so one of the critical components is keeping things out of the way, keeping the spheres clean and clear of debris, everything face down. We'll go through that. So why do we do it? There's tough areas to see that, Dr. Chambers has done screws for 20 years without even really taking fluoro shots. Why do we do this? Well, as you guys have seen in the year and a half, 2 years that we've had O-arm and Stealth here, it's opened things up. We've done more thoracic procedures, posterior cervical procedures, minimally invasive procedures, because you can visualize things better than you can with 2D fluoro and do it with confidence. And it reduces the time that your patients are on the table by eliminating some of the struggle and exposure, blood loss, those things. So you can see here's just kind of an example of, okay, in this image, you can't really see high shoulders, thick neck, what's going on. But when you take a scan, there's a problem. Look at that. You can't see that there. So those things that you can see intraoperatively that you couldn't see with just a fluoro shot become apparent. Okay, so here are those scrub and room considerations that I was talking about a little bit earlier. Clear line of sight. Keep hands and drapes away from the field from blocking the spheres. We'll have someone come up on hands-on. You have to make sure that those spheres are fully seated onto the instruments or the nav lock frames to make sure if they're not seated all the way, the camera knows the geometry of that instrument. If it's not on there all the way, it won't recognize it and we won't be able to see it. Clear and dry, face down, the camera gets confused if it sees, it likes to see two things. When it sees three, it doesn't know what to do. It'll flash, it'll flicker, and we won't see what we want to see. So always, if it's not in use, face down on kind of a clean, dry area. And one of the most important things is be mindful of the patient reference frame, whether it's the PERC pin that he puts into the PSIS or spinous process clamp. If you see it get bumped, be mindful and don't be afraid to say something, because if that gets bumped, it can shift because the camera in the computer doesn't know, it still sees that frame and it imagines it's exactly where it was in that snapshot of time when we took the spin. But if it's moved, well, we're not going to be accurate any longer. So if you bump it, don't be afraid to say something, because it can, if we place screws or do instrumentation and it's moved, well, we've just added time to the case, because there's a potential where we have to move, replace or redirect the instrumentation because of the accuracy. All right, last question. Who is Bonita's favorite rep?